Hi, my name's Connie Koklanis and you're watching the video on prescribing occlusion. Specifically, we'll be discussing the types of regimes we would prescribe for the various types of occlusion methods. And this will be based on many of the studies that had been undertaken by PDIG, the Pediatric Eye Disease Investigator Group. In the past, much of our understanding of how to treat amblyopia was based on low-level evidence, so cohort studies as an example, or non-randomised controlled trials. And PDIG more recently has endeavoured to undertake a series of studies which include high level of evidence to support how we go about managing patients with amblyopia. Let's commence with optical management. Now, in an earlier video, I mentioned that when we're managing a patient with amblyopia, if we elect to prescribe glasses for refractive error, then this is the very first thing that we will do in terms of managing the amblyopia. And PDIG has shown that the glasses alone can improve visual acuity for patients. So I always prescribe glasses first and nothing else, no occlusion, patching, etc. The only time I would prescribe both glasses and occlusion at the same time is if the child is older and I'm towards the end of the critical period, which means that I don't have as much time to manage the patient's amblyopia. But generally, if they present young, it is best that you commence with the optical management of the patient and then review your patient in about 2 months' time and see if there's an improvement in visual acuity. Now, if the visual acuity is improving in the amblyopic eye, then it is suggested that you continue to just have the glasses on until the VA in the amblyopic eye stabilises. And if it stabilises at a point where amblyopia still exists, then this is when you commence occlusion treatment. Let's move on to patching. We're going to deal with patching separately to pharmacological penalisation. Now, when we prescribe patching, we have one of two options. We can either ask the patient to wear the patch full-time, which means they have to wear the patch all waking hours, or part-time, which means you might prescribe 6 hours or 4 hours. So anything less than all waking hours. Now, when should you prescribe full-time and when should you prescribe part-time? It's interesting to note that many orthoptists in the past used to prescribe full-time total occlusion, total again being that there's no light entering the eye, so no form perception occurring. They used to prescribe full-time total in patients with about 6/18 vision or less, and part-time occlusion for patients with 6/12 or better. So what you're looking at is the more severe the amblyopia, the more occlusion you should prescribe, versus the milder the amblyopia, the less occlusion you can prescribe. However, PDIG began studying the differences in terms of visual acuity outcomes of patients who were prescribed full-time versus part-time. What were the findings? Well, PDIG has shown that there really isn't that much difference between prescribing full-time occlusion versus part-time occlusion, or even prescribing 6 hours versus 2 hours. So both of those are part-time, one more than the other. Essentially, it might take longer for you to achieve the visual outcome if you go part-time, but the long-term outcome is very similar. The child will improve in visual acuity no matter what you prescribe. This, therefore, has changed a lot of orthoptists' practices such that many have moved to prescribing part-time occlusion. The reason being that full-time occlusion is very difficult to achieve. Having a child wearing a patch all waking hours is not easy. Compliance can be really difficult. Not to mention that when you've got full-time occlusion occurring, the child is going to school with the patch if they're of school age. So should they have severe amblyopia, they go to school with very reduced visual acuity in that eye. So with part-time occlusion, if you're prescribing 2 hours or 4 hours, they can be done outside of school hours. You could even break up the 4 hours. You could do, for instance, an hour in the morning and 3 hours in the evening, or 2 hours in the morning and 2 hours in the evening, depending on the flexibility of the patient's time. The other belief in the past was that when you prescribe amblyopia treatment, patients should be asked to undertake near tasks during amblyopia treatment. So whilst you're wearing the patch, you should be colouring in, doing a detailed task in order to force the use of that eye. PD has again looked at this and has suggested that there isn't yet evidence to suggest that you have to do near work in order to achieve optimum visual acuity outcomes. So it is sufficient enough to ask your patient to put a patch on for X amount of hours and that they go about doing whatever activity it is that they're doing during that time. Now, when should you review a patient who you've prescribed patching to? The main consideration here is that you do prevent or don't cause occlusion amblyopia. So occlusion amblyopia is when you reverse the amblyopia and the non-amblyopic eye or the sound eye becomes amblyopic. So you've gone too far with your treatment. Now, say for instance you put a patch on all day, every day, all waking hours and didn't see the patient in 6 months, more than likely you're going to create occlusion amblyopia. So we need to have a rule of thumb that guides us as to when to review the patient. And the rule of thumb is that if you prescribe full-time total occlusion, then you should see them 1 week for every year of age to prevent occlusion amblyopia. So what that means is if you've got a 2-year-old, you see them in 2 weeks. If you've got a 5-year-old, you see them in 5 weeks, and so on. So you can see how if you're prescribing full-time total occlusion, you need to be regularly reviewing them. The reality is that most orthoptists are not currently prescribing full-time occlusion. They're prescribing part-time occlusion. And as such, you can be far more flexible with the review period. And generally, we would recommend that you see your patient within 6 to 8 weeks, so within 2 months, or even 3 months. Now, you really don't want to go beyond 3 months because it's difficult for a patient to maintain motivation for their treatment if they don't see you and see how they're going and what their progress is in terms of their visual acuity. So it's a good idea that even if you're doing maintenance occlusion, which we'll talk about in a moment, that you see them within 3 months to encourage them to keep going and to see what's happening with this visual acuity. Now, when you're prescribing patching, you're going to have to be flexible in adjusting your treatment. And here is a list of reasons why you might adjust the treatment. So for instance, if we take a look at the first comment there, visual acuity is not improved after 1 or 2 treatment intervals. So what we mean as 1 or 2 treatment intervals is that you've seen them in 2 months and it hasn't improved, or you've seen another 2 months, so twice within 4 months, and again there's been no improvement. So at this point you need to consider an alternative. So either compliance is an issue, in which case you can give your patient strategies around how to become more compliant or how to induce the child into taking part or an active part in their occlusion regime. Or if the child is compliant, then you may need to change what you're doing, increase the hours, change to pharmacological penalisation, etc. I won't go through all this table, but it's a good list to give you an idea of when you consider changing the regime you've prescribed. Before I move on though, I want to make one more point around this statement here. Strabismus and or diplopia develop. And it says here temporarily stop treatment and monitor. So here we have a situation where you're occluding and diplopia develops, which means that you may have potentially anti-suppressed your patient. This is when you stop all treatment and then you wait and see what happens. And hopefully they will revert back to being suppressed and therefore diplopia will be relieved. Then you'll have to make a call as to whether it's worth continuing occlusion treatment at the risk of having intractable diplopia. The other possibility is that strabismus will develop. Now what this means is that you had what appeared to be a relatively straight patient and now all of a sudden they have strabismus. Now generally these patients are not straight patients. More often than not it occurs in a patient who has a microtropia, so a small angle strabismus of about 5 degrees, and then occlusion, or the dissociation of occlusion, causes an increase in the angle of deviation, and it might go, for instance, from a 5-degree eye turn to a 25-degree eye turn. So here we have a patient who the occlusion has caused a cosmetic issue. Previously, cosmetically, the patient was fine, even though there may have been a small angle strabismus, and now all of a sudden your patient has a cosmetically noticeable esotropia, and on top of that, they're probably going to have diplopia. If you are treating a microtrope, it is important to warn your patients of the potential of a larger angle strabismus, and to stop treatment immediately if they notice a large angle strabismus. So it's important that you've diagnosed the microtropia before you commence treatment and fully inform your patients of the risk. Okay, when do we stop occlusion and how do we go about doing this? Well, firstly, you'll stop occlusion if you've achieved your aims, which is equal vision, or you have residual amblyopia that you just cannot seem to treat. So you've tried alternative treatments, you've tried increasing the patching, you've tried optical penalisation, pharmacological penalisation, etc., and you're just not getting success. And if compliance was an issue, you also tried strategies to improve the patient's compliance. We consider VA stable when you've at least had 2 or 3 visits where there's been no change in the visual acuity. Okay, so let's say we're at the point where we've got stable residual amblyopia or we've got equal vision. Do you abruptly stop occlusion? There is suggestion that you should not do that. You should wean off the patching. So if you were doing 6 hours a day, then you reduce it to, let's say, 3 hours a day, and then to 1 hour a day, to eventually not having any occlusion. Or you could say you were doing 6 hours every day, and you could say, let's do 6 hours every second day. There is no right or wrong in terms of how you wean a patient off, and usually this will be determined by your conversation with the parent and the child and see what works best for them, and the parent will know whether the child is better off having the patch every day by a reduced amount as compared to wearing it one day on, one day off, or having weekends off, or however you decide to wean the patient off. The other consideration is that you don't actually wean your patient off, but you do what's called maintenance occlusion, which means that you continue to patch by a small amount in order to maintain the visual acuity that you gained. Generally, you'll have to gauge the risk of the recurrence of amblyopia as to whether you feel that you need maintenance occlusion or not. So if, for instance, the child has 6666 VA but has a left esotropia, well, then no occlusion may lead to amblyopia recurring, particularly if the child is young, if they're still 4, for instance. If they were 7, then really you're at the end of the critical period, so it's less likely to develop. So you need to gauge what the risk is. Okay, now let's move on to pharmacological penalisation. When do we prescribe pharmacological penalisation? Patching is the gold standard first-line treatment method for amblyopia. So 99% of the time you will prescribe patching in the first instance. So pharmacological penalisation is a second-line treatment, is often considered after patching has been tried. However, there are instances where it might be considered to be better used as a first-line treatment. The first is if you have a patient with nystagmus such as late nystagmus. In this instance, when you occlude the eye, you're obviously eliciting the nystagmus. So it may be better to use pharmacological penalisation in this instance so that you don't elicit the larger amplitude nystagmus through monocular viewing. Another instance may be that you have intermittent strabismus that breaks down very easily upon dissociation. That may be a consideration where you want to keep both eyes open to prevent dissociation. However, more often than not, it's prescribed in patients who've had poor compliance with patching. Patching has not been successful, so you're trying something different. And it has been thought in the past that the patients that best respond to atropine are those who have about 6/12 visual acuity or better. However, PDIG has shown that patients with severe amblyopia can also be successful with pharmacological penalisation. So it is worth trying it in these patients, even though pharmacological penalisation is unlikely to change the fixation of the patient. Okay, what do we prescribe? We prescribe 1% of atropine for the non-amblyopic eye. In terms of the regime, PEDIC has shown that 2 days of atropine, consecutive days, so let's say Saturday and Sunday, are just as effective in giving you a visual improvement in patients with amblyopia as instilling atropine every single day, Monday to Sunday. The reason they looked at this is that you can imagine that if you're putting atropine in every single day, the child, if they're of school age, are going to school with a cyclopleged eye and blurry visual acuity. So the idea here was to look at whether you can prescribe atropine on the weekend so that when the child goes to school on Monday, their visual acuity is starting to return. And then through the week, they'll have good VA. So given this study, most now would prescribe or commence with atropine 1%, 2 days a week on the weekend. And if there's no improvement with this, then you look at increasing the regime to perhaps daily or even 3 or 4 times a week, depending on what you want to prescribe. Now, if you find that atropine is not improving the visual acuity, you also have the option of introducing optical penalisation in order to further defocus the visual acuity of the good eye. So you might commence with atropine and optical penalisation, or you might choose to see whether atropine alone can improve the visual acuity and introduce optical penalisation if there is no improvement. Now, when do we review a child who we've prescribed pharmacological penalisation? If you're prescribing atropine 2 days a week, so on the weekends, then effectively you're prescribing part-time occlusion. So you can review them as you would a patching patient, say in 6 to 8 weeks. The issue becomes if you prescribe daily atropine, whether you should see them in 6 to 8 weeks or whether you should see them sooner. What you don't know when they leave your clinic and you've prescribed atropine is whether if they will have a fixation swap at near and far, or whether they'll simply have a fixation swap at near. If they have a fixation swap at near, again, effectively you've got part-time occlusion occurring, because in the distance they'll prefer their non-amblyopic eye and at near their amblyopic eye. If there's a fixation swap at near and far, then effectively you've got full-time occlusion occurring, because every day that you put that atropine in, the child is preferring to use the amblyopic eye. So you'll have to gauge whether you think the patient is likely to have full-time versus part-time occlusion with pharmacological penalisation. If you are concerned that you're prescribing atropine and you may get a full-time treatment and end up with occlusion amblyopia, then you could perform an in-clinic test called the fixation swap test. The fixation swap test is essentially you put cyclopentolate in one eye, in the non-amblyopic eye, you send the patient away for half an hour, and then they return and you have a look at whether the patient has swap fixation at near and far. And that will give you an idea of what will happen with atropine. The other way you can do it is that you prescribe the atropine, see them soon, like in 3 weeks, 4 weeks, and see them with the atropine in the eye. Preferably they've instilled it that morning, and see whether there is a swap-in fixation, whether it's occurring at near and far, to then guide you as to how much to prescribe thereafter. The other point to make is that when your patient comes to clinic with atropine in their eye, then you can't assess the visual acuity of that eye because it's cyclopleged. So if you want to monitor visual acuity and any potential occlusion amblyopia, you need to ask your patient to stop the atropine at least 3 days before they see you, and even up to 1 week. Now, in terms of seizing, weaning, maintaining and adjusting treatment when you're using pharmacological penalisation, You'll use the same principles that we just discussed in relation to patching. In terms of maintenance occlusion, you could utilise atropine for maintenance, but you need to consider how long the patient will be on atropine for. You don't want to be maintaining visual acuity using atropine for years at a time, as an example. So overall, in terms of prescribing amblyopia treatment, you need to tailor it to the individual, and then using the best available evidence to guide you in terms of the hours that you may prescribe. Often, there isn't a right or wrong approach to managing your patient with amblyopia. As long as you're seeing improvements in visual acuity, then you're on the right track. And as long as, again, you're using evidence-based practice in your approach. Now, on this slide, what I've given you is some of the things that you may need to consider as you manage your patient with amblyopia, and also some of the key things that you will need to discuss with the parents when you're prescribing treatment. I'm not going to go again through the list here that I've provided, but I want to bring your attention to one thing that I've written here, which is to tell the parents that alternation is the aim, it's a good thing. What this means is that when you achieve equal VA, if the child has strabismus, it's likely or it's possible that the child may commence alternating. So the child will present, as an example, with a right ET and right amblyopia. And then through amblyopia treatment might become an alternating esotropia, which means sometimes they have a right ET and sometimes they have a left ET. Now, if you do not warn your patient and their parents that the left eye may begin turning, it will be a shock. And they will become extremely worried about why the strabismus has now moved over to the left eye. So informing the parents is critical in the success of your treatment. Okay, before we conclude, I just want to bring your attention to the website or the PD website where you can find the series of papers that have been published on amblyopia. The way we manage amblyopia today is primarily due to the PD research. Okay, that brings us to the conclusion of this video. Thank you for watching.